Bienvenidos a otro segmento de CRF News. Hoy les traemos una charla muy interesante que fue presentada en el curso de los fellows de nosotros este año, que fue dada por el doctor Nicolás Lembo de nuestra institución. Y es muy interesante porque en el curso de los fellows nosotros no solamente damos las charlas, pero tratamos de ser muy específicos y muy detallados en cuanto a los guidelines, pero también hacerlo muy interactivo con preguntas y respuestas. Esta charla básicamente está enfocada a la parte que es básica del entendimiento del manejo del síndrome coronario agudo, una entidad que, como lo sé, es demasiado común en Colombia y en Latinoamérica. Espero que de verdad la disfruten porque tiene una combinación muy interesante de lo que es evidencia basada en medicina y en los datos, con un tópico muy interesante que es la parte de preguntas y respuestas para hacer la charla un poco más ameno. Espero de verdad que la aprovechen muy bien en un tema tan importante en nuestro país. Muchas gracias.
So we'll start out, here's my disclosures. We're going to take it from the non-PCI hospital because we never see those patients anymore. We never give thrombolytic therapy, but you need to know how to do that. From early hospital care, then we'll go take that same patient to the cath lab. We'll talk about some of the mechanical complications of myocardial infarction and then the late hospital discharge. So here we are with the non-PCI hospital. So the first question, question number one, 52-year-old patient comes to the within 4 hours of the onset of chest pain, presents to the emergency room with an acute inferior wall myocardial infarction. He's hemodynamically stable, and there's no contraindications for fibrinolysis or PCI. Your hospital does not have an on-site PCI capability, but is part of a STEMI network with the ability to transfer the patient. There's always a snowstorm on these questions on the boards. And air transport is not available, but ground transportation can be arranged. Which of the following is the key estimated time to treatment that will help guide your choice of therapy? A, your hospital first medical contact time to receiving hospital catheterization lab arrival time of less than 120 minutes. B, your hospital first medical contact to receiving hospital balloon time of less than 120 minutes. C, your hospital first medical contact to receiving hospital arrival time of less than 120 minutes. D, your hospital first medical contact to balloon time of less than 180 minutes. And E, your receiving hospital first medical contact to balloon time for your primary less than 90 minutes. And the answer is B, your hospital first medical contact to receiving hospital balloon time of less than 120 minutes. So give yourself a check if you got that right. Give yourself an X if you got that wrong. So we all know what to do in our STEMI hospitals. You want to get the first medical contact to device time of less than 90 minutes. But we don't see that much what to do in a non-PCI hospital. And you want to administer fibrinolytic therapy within 30 minutes if your anticipated first medical contact to device time is greater than 120 minutes. If it's less than 120 minutes, transfer them for primary PCI. And then you have the option after if you treat them with fibrinolytic therapy, to transfer them urgently within 3 to 24 hours. With the exception that if you get a patient who gets thrombolytic therapy that's in impending shock or in shock, if they ask that question on the boards, you need to get that patient immediately to a tertiary care facility. So that's a class 1 indication for transfer. You all need to know I've never given thrombolytic therapy for an MI ever in my life, but you need to know all the indications because they're going to ask you those on a board question in a patient who there's a snowstorm and the ER doc is asking you, should you get thrombolytic therapy? So know these absolute contraindications. Remember that prolonged CPR of greater than 10 minutes is only a relative contraindication. Okay, our next question. A previously healthy 82-year-old female presents to the community hospital within 5 minutes of an anterior, with 5 millimeters of anterior ST segment elevation. She's having a STEMI. Her hospital is far away. She has no fibrolytic therapy contraindications. You recommend full dose lytic therapy along with aspirin, 75 milligrams of clopidogrel and heparin, and then she's transferred to your hospital. Her blood pressure is 100/70. She's not having any further chest pain, but she does have some mild diaphoresis, shortness of breath, as well as 3 millimeters of ST segment elevation. What's your immediate next step? Activate the cath lab A, continue medical therapy B, add a glycoprotein 2B 3A inhibitor, and D, give an additional fibrinolytic drug. What they want you to look for on this one is that she still has some symptoms, and you need to activate the catheterization laboratory because she hasn't, in addition to having some dyspnea symptoms, she hasn't dropped her ST segments by more than 50%. So if you remember, her ST segments were 5 millimeters, they're 3 millimeters now. So she hasn't dropped her ST segments greater than 50%. That's another indication for taking that patient emergently to the catheterization laboratory. So those two reasons. So you're in the cath lab. You're taking her to the cath lab. She's gotten her aspirin. How much? And she's gotten 75 milligrams of clopidogrel. What agent should she receive now? Right before your catheterization, should she not receive any more P2Y12 inhibitor? Should she get 300 milligrams of clopidogrel? 600 milligrams of clopidogrel, or 60 milligrams of prasugrel. If you remember, she's 82 years old, so prasugrel's out. The big thing is how much clopidogrel she should get. And you need to know on the boards that patients who have gotten thrombolytic therapy, who are going for PCI, if their thrombolytic therapy, if their PCI is within 24 hours, they only want you to give that patient 300 milligrams of clopidogrel. And it's only if it's after 24 hours that you give them the full dose. And I don't know what the reason is, maybe because the bleeding complications were thought to be risk.
The trials were done with 300. It was before the 600 load. That's how old those trials are.
But that's what it comes down as far as answering that question on the boards.
Just so you know, there was recently a modest-sized study called the TREAT study looking at thrombolytic therapy with ticagrelor versus clopidogrel, which suggested ticagrelor was safe in that setting. So maybe that's going to get a 2A. We'll see how that changes.
All right, let's go now to your ACS acute. Now you're in the hospital. We all know what to do, but the board loves to tell you what they like to ask you questions. What's harmful? So you really got to know the class 1. You guys know all the class 1 indications for this, but I just want to hit the class 3 harm indications for treatment. So nitrates are contraindicated with any recent phosphodiesterase inhibitor. Non-steroidal anti-inflammatories should not be initiated and need to be stopped in patients coming with non-STEMI and ACS because of the increased incidence of ACE. Don't give any sort of IV beta blockers when anybody's going into shock or in shock. And immediately release nifedipine is contraindicated in the absence of a beta blocker. All right. This next question is a tough one. You're asked to evaluate a 50-year-old patient admitted to the hospital for chest pain. She has no prior coronary disease. She's not taking any cardiac medications. She has hypertension, doesn't know her lipid status, and is a current smoker. She has sudden onset of severe chest pain associated with nausea and diaphoresis, which resolves with nitroglycerin. She has been chest-free since admission. Her serial troponin values were negative. Which of the following best reflects the current guidelines for treatment of this patient? So 50-year-old, severe chest pain, nausea, diaphoresis, troponin negative, not having any chest pain now. So an early invasive strategy with decrease her risk of urgent revascularization and myocardial infarction and death. CKMB should be measured. Aspirin therapy should be deferred until risk stratification. Non-invasive risk stratification is preferred. And her response to nitroglycerin suggests a coronary etiology and catheterization should be pursued. Let me see your hands who said A, B, C, D, and E. All right. Greg and I got this wrong.
I got it right, they got it.
And the reason is a non-invasive therapy, and class 3 is obviously is for patients with extensive comorbidities, but what they're looking for is acute chest pain and a low likelihood of ACS with troponin negative, especially in women. The boards don't want you to do an early invasive strategy. They want you to risk stratify that patient. So I got that wrong, and it also said in the answers that the response to nitroglycerin, don't let that sway you either way, because as much patients with CAD responded in the same way as patients without CAD. So,
Nick, in all honesty, though, the smoking would impact me more than a nitroglycerin response. Is she really low likelihood, or is she intermediate to high?
yeah.
So I'll tell you why I would still cath that patient. So all the studies by intention to treat show a benefit of an invasive approach compared to a conservative approach. Then if you start looking at subgroups, okay, you see that the greatest benefit is in high-risk patients, whether you use a TIMI risk score or a GRACE unstable angina risk score, with kind of an intermediate benefit in intermediate risk patients and a low benefit or perhaps no benefit, but again, no harm in lower risk patients. Subgroups are secondary analyses by intention to treat overall patient's benefit. And to me, you get that patient to the cath lab with a very low risk procedure. You find out if she's got coronary disease or not, and if so, she had nausea, diaphoresis, she may have a large amount of myocardium at risk. I would still, knowing that there's no overall harm, would still cath that patient. But you're right, the boards
don't want you to cath that.
Well, CTA is a non-invasive test, and that would maybe the one.
You could do CTA. Absolutely, you could do CTA.
All right. This is a 37-year-old unemployed male who's been partying all evening using cocaine and methamphetamine. He's brought to the emergency room at 11 p.m. by his friend because he's complaining of some vague chest pain. The patient demonstrates acute signs of intoxication manifested by euphoria, tachycardia, his blood pressure's up, his chest pain is now completely resolved, his EKG is completely normal, his first troponin is mildly elevated, and his second troponin is 3 times the upper limit of normal when you get called. You recommend an early invasive strategy with cardiac catheterization in the morning. You've been studying that evening for the interventional cardiology boards, so you recommend to the hospitalist who will be admitting the patient all of the following, which are class 1 indications, except for supplemental O2 if the oxygen's less than 90, beta blockers, aspirin load and maintenance, clopidogrel load and maintenance, fondaparinol 2.5 milligrams sub-Q, and statin as well. So
So this is like a typical night at Dwayne's house, so maybe he should tell us what he would do.
So based on
generally, I find that the unemployed have a hard time affording their cocaine, but I think there's 2 here that are wrong. I would say that when I'm selecting an early invasive strategy, funded Paranox is not something you want to use because of the associated catheter thrombosis. But if someone's intoxicated with cocaine, I think I generally don't use beta blockers either.
Yeah, the answer that's the answer they're looking for, and if you you could use the beta blockers from a class 1 if they're on a vasodilator. But if they're not on a vasodilator, beta blockers should not be administered in patients with ACS with recent history of cocaine who demonstrate acute intoxication because of the risk of potentiating spasm. All right, next question. 58-year-old patient who lives in Boston is watching the Patriots versus Eagles Super Bowl. He has a cardiac arrest at the end of the game. Paramedics arrive within 5 minutes. They quickly cut off.
I don't think you should be shooing Dr. Gibson's protected health information.
They quickly cut off his Tom Brady jersey, and CPR has begun. I'm still angry that the Patriots beat my Falcons 2 years ago. So, but he's quickly defibrillated at the scene. Upon arrival to the ER, he's comatose. Blood pressure's okay. Pulse is okay. EKG shows an acute anterior STEMI. No prior cardiac history, no contraindications to thrombolytic therapy. Appropriate management in this PCI-capable hospital would include therapeutic hypothermia, thrombolysis, immediate angiography and PCI, A and B, A and C, A and B or C. And the answer is therapeutic hypothermia for sure, and take this patient immediately to the catheterization laboratory to see what's going on. They don't want you to use thrombolysis. You need to take this patient to the catheterization laboratory if he's a suitable patient. And it's a 90-year-old from a nursing home with 30 minutes of CPR. That's another story. You need to know how to use the risk calculators. We won't go over this. You guys know how to use those. You need to know who to urgently cath who's having a non-STEMI ACS, refractory angina, signs and symptoms of heart failure, hemodynamic instability, recurrent angina, or ventricular arrhythmias. And this is a question that we've kind of addressed already, that we won't have to answer this, but this is basically the board's asking you, a patient is having a STEMI, they have clot in the LAD, and they just got aspirin and heparin, and what else you should give. And what they're looking for, and there's no cangrelor on the slide, so that what they want you to remember, if the only choices you have are clopidogrel and prasugrel of what to do, and a patient hasn't seen it and you're in the laboratory already, they want you to remember that there's still a class 1 indication to use a 2BA3 inhibitor in patients having an acute infarction who haven't been pretreated with dual antiplatelet therapy. So that was kind of a question just to remember those things are still indicated. This was a question I think we addressed already in Dwayne's answer. If you have a patient on fundoparanol before the procedure, you're not going to use that procedure in the cath lab because of increased stent thrombosis. You're going to fully anticoagulate that patient with heparin. We touched on this already, that routine thrombus aspiration is now a class 3 indication, and we already touched on this, that it's doing other vessels. Multi-vessel PCI is a 2B indication. It comes from a class 3 indication in patients with multi-vessel disease and non-STEMI ACS. Let's look quickly at the mechanical complications of myocardial infarction. We're going to touch on VSDs, acute mitral regurgitation, and free wall rupture. This is a patient, a 66-year-old patient coming to the emergency room with chest pain 2 days, that's been going on for 2 days before his admission, but he comes to the emergency room now because the shortness of breath is now severe and acute. He has a systolic murmur, grade 3/6. He's got an S3. And they're asking you what's going on. And he's short of breath. So did he anterolateral papillary muscle rupture from an occluded LAD, anterolateral papillary muscle from an occluded right coronary artery, posterior medial papillary muscle from an occluded marginal, or posterior medial papillary muscle from an occluded right coronary artery, or a VSD? It's not a VSD. He's mostly short of breath. And what they're wanting to look for is he's got a posterior papillary muscle rupture because it's an acute shortness of breath. He's a couple of days out from an infarct. And all these other choices are not correct. And be aware that the posterior medial papillary muscle has only one blood supply, whereas the anterior medial papillary muscle, anterolateral papillary muscle has a dual supply from both the LAD
Nick, if you
and the
go back to the description too, that history is actually typical for a rupture. Is I had chest pain and then I had it again, and then the radiation of the murmur too anterolaterally is more suggestive of the direction of the jet is obviously thus anterior, and that's probably the posterior leaflet. So that is also suggestive.
Suggested.
But the other thing is that patients don't always come in saying that I had chest pain 2 days ago and now I'm having chest pain again. So it makes it sound like it's an acute event, but it could be a rupture of some sorts. And so that exam, that initial exam is really important, listening for the murmur and seeing if they're hypotensive. Then it's worth taking the time and doing an LV-gram.
By the way, raise your hand if you've cathed somebody, intervened upon them, and no one has actually listened to their heart. Yeah, all right.
That's one of the things that I always do is listen with, don't ask the fellow, I listen to everybody who comes in, because you're going to get burned on the ones that are a couple of days out. And I'm old school, I always do a V-gram, and I do it in both views. And if I hear a loud murmur and I do that, I do a full left ventricular gram, because I don't want to do a right coronary artery stent in somebody who's got that ventriculogram. That's as completed infarct as you can get. And when the papillary muscle ruptures, that's as complete of infarct you get. And if you start doing interventions on those patients, that's going to give you almost 100% mortality.
The key points here are the proper projection for a V-gram if you're looking for a VSD is in the LAO projection, LAO 60, maybe a little cranny on it. And then when you do a right heart, when someone looks out of proportion sick, like an inferior MI and they look horrible, something is going on. You probably end up doing a right heart cath, but don't cut corners. Get the SVC sat, because when you get a PA sat of 75, and you say, they're pretty good, their cardiac output is high. It might be because they have a VSD.
Mm-hmm. Most of the times you're not going to see a free wall rupture in the cath lab, but you're going to, because those patients die. But here's a good angiogram of somebody who's just about to rupture. And if you see that on somebody who comes in and he's got that just impending rupture, don't stent that right corner, don't open up that right coronary artery, because that's going to be another death on your scorecard, because that patient, that angiogram, actually that patient ruptured in the cath lab shortly thereafter. So be very careful. Most of the time you see rupture is somebody does an echo post-code, and you could see on the echo on the right, you see the big pericardial effusion, and you could see the hole in the wall. Those are...
I will also echo what you said, no pun intended. I think it's very important in every primary PCI to do an LV-gram, almost in every single case. And I can tell you, Bill, Cindy, and I still believe you should do it before you open up an infarct vessel. Because one, you're going to know the hemodynamics. It's going to help you manage that during the case. If the left ventricular diastolic pressure is 3 versus 30 and the patient goes south, it totally changes your management. 2, you know the left ventricular function, but you will pick up occasional mechanical complications that you didn't suspect. And I've had, I'd say probably 6 or 7 cases of total in my career, VSDs and papillary muscle rupture that were unsuspected, and 3 aortic dissections. And so for the 30 cc's or 35 cc's of contrast and the 5 minutes it takes to do an LV gram, it is well worth it.
In some of these cases, you don't hear a systolic murmur on some of these severe mitral regurg patients. And just be aware that when you see on the boards, when you see mechanical complications of myocardial infarction, a VSD or a ruptured papillary muscle, even though we got tricks now, we could use a mitral clip for the, all these things. The board doesn't want to see you do those. They want those patients to be treated, your VSDs, your ruptured papillary muscles, with surgery. That's the answer they're looking for. Don't take them to do a mitral clip. This is the last question, and it's going to probably...
But I will say you, that being said, there are plenty of case reports now of people whose lives have been saved, anecdotes of acute mitral clip in cardiogenic shock due to papillary muscle rupture. And it's much safer than going to surgery in that setting. So, again, there's what the boards say. These guidelines are usually 2 to 3 years behind all the evidence and practice. So as a practicing physician, these are guidelines. They are not, doctrine and legal mandates.
This last question is going to irk everybody on the panel. A 48-year-old man comes in with an anterior ST segment elevation myocardial infarction. He's in cardiogenic shock. His blood pressure is 80/50. He's on a non-rebreather. Initial angiogram just shows diffuse clot in the left main and large ramus with abrupt angiographic cutoffs in the mid-LAD. The right coronary artery is normal. Which is the following among the next best steps in management? And the choices are intra-aortic balloon pump, coronary thrombectomy, and left main PCI. Start vasopressin, intra-aortic balloon pump, and coronary thrombectomy. Start neosynephrine, intra-aortic balloon pump, and left main PCI. Intubate, intra-aortic balloon pump, and left main PCI. Start dopamine, 10 mics per kilo per minute, intubate, and place an intra-aortic balloon pump. Dimitri? None of the above. All right. And I took these questions from CathSat 5. So this is not old stuff. This is CathSat 5 that just recently got published. And the answer they wanted was start dopamine at 10 mics, intubate, and place an intra-aortic balloon pump. A balloon pump, it's great. But what the boards want you to do when you have somebody in cardiogenic shock.
Put in a balloon pump?
Class 3 right now. Class 3 in the guidelines to put in a balloon pump.
Yeah. In the European. In Europe, this is the American board.
Well, again,
it's too big, isn't it?
I knew this would get everybody upset. What they want you to do when you put a support devices, they want you to first stabilize with pharmacologic therapy. There were multiple questions in CathSat 5, and they all mandated you to start pharmacologic therapy first, and then you're allowed to do it. So don't shoot the messenger on this. I knew this was.
I think if I were taking the boards, I would silently protest and not answer.
Answer that question. Okay, I'm pretty much done here now. Know that the patients get a defibrillator if they have VTAC or VFib within more than 48 hours after their STEMI, and know that you don't want to use in management of pericarditis both steroids and non-steroidals or class 3 indications. You want to use aspirin for that, possibly acetaminophen or colchicine or narcotic analgesics if they have pericarditis, and then know all these, they should get good follow-up, they should be in a rehab program, stop smoking. So thank you and good luck on the boards.